Assalamualaikum and a very good morning. Hopefully you all still fresh. Okay, I think most of you involved in OT and ICU. But regarding retained foreign body after surgery, or the familiar name is retained surgical foreign body, RSFB. So it's very important for you all to know this. Okay, I will cover a few topics regarding this retained surgical foreign body. I will give introduction, risk factor related to it, what happened when this happened, and how we can prevent it, and then at the end will be conclusion. Okay, retained surgical foreign body. Definition: any item inadvertently or you unintend to left behind in patient body after operation. So it's cover any type of operation, orthopedic, surgical, whatever operation. So you normally people not intend to leave with the instrument. So we must avoid it. The incident of retained surgical foreign body is literature is difficult is for us to know is it the exact incident. It's about less than 1%. If you remember, if you operate in your hospital surgical case about 2000, the incident should be less than 2, or maybe it should be less than 1. If to compare to international incident level. But this problem because the reporting normally not by medical personnel, more to legal suit. The data come out from the lawyer. Because people scared to report, because when you report retained foreign body, they will invariably the patient will know, and then, oh, doctor left something, so it's time to sue the hospital. So actually under reporting. So it's maybe more than this. The good thing, most of the retained surgical foreign body detected immediately. And one more thing about retained surgical foreign body, it happened when humans start operating. So it's from beginning of operation, century ago to 2000 decade before, because it's when you start surgery, sure this thing can happen. Okay. Regarding the retained surgical foreign body, normally can be identified immediately because normally in OT you all do the swab count, instrument count. If not correct, then normally we search for it, but mostly detected immediately. But few of them undetected for years or even decade. Sometimes patient come maybe operation about 20 years ago, they come back 20 years later with different symptoms. People diagnose them as they presented with obstruction, and then CT scan show the tumor. When they operate the tumor, true like the tumor lah. When you open up the specimen, there's gauze inside it. So that can happen after 20 to 30 years. Regarding retained surgical foreign body, they got two types, common types lah if you want to remember. The textile based type. Normally in OT we use what? Gauze, swab, abdominal pack. Even towel also sometimes can found in the patient body. Don't be surprised. Your draping towel, maybe the small towel, I'm not sure last time they use small towel. Towel also can found inside patient body. Don't be surprised. And now with laparoscopic, I think got small gauze, right? If you all assisting laparoscopic surgeon, sometimes they use a smaller gauze. Okay, then the other non-textile. Post-op, sometimes people insert drain, or even during vascular surgery, they implant the graft, or maybe even the clip. Kalau the surgery, sometimes you use stapler, a lot of things. Sometimes you forget even needle. Needle break, leave inside patient body. Sometimes so you must check your needle. Surgeon, when the surgeon pass you back the needle, sometimes please check like sometimes the needle sometimes the tough tissue, the surgeon struggle, the needle can be king. By the time second stroke, where's the tip? So be careful, Scissors, scalpel, even electrosurgical adapter also can find in patient body. Your diatomy connected because your diatomy kan you change your short, long pin. Sometimes the pin also sometimes this can happen. But the most important thing, the single most common left object is sponge. So it's important your count sponge count. Don't make mistake. Kalau inaccurate, please recheck. Okay, what is Gossypiboma? Actually, Gossypi is the Latin word for cotton. Oma tu tumor. That's why most of this case they end up with tumor. When you open up the tumor, there is a granulation tissue around it plus the gauze inside there. Sometimes the gauze still intact like original. We just keep there for years and years. Okay, what are the risk factor? It's 9 times common in emergency surgery. For example, like you work in OT middle of the night, ada intra-abdominal injury, everybody panicking, BP low lah, rushing there, rushing here. The surgeon said, come give me PAC. 1 pack, 3 pack, sometimes 5, 6 pack. You must faster counting. The nurses in OT, you make sure you do whatever you do to remember how many pack the surgeon use. In my hospital, sometimes I use artery forceps. Everyone goes in, they click on the. Make sure you remember. Or maybe you can differentiate abdominal pad dengan gauze. So if possible, avoid using small gauze. Use pack. Sometimes they use roller gauze. Even that you must go on roller gauze how many. And then another thing is unplanned change surgery. Suddenly intra-op finding differently and need to call ONG lah. And then ONG come in, the surgeon stay back for a while and ONG do his part. And then the thing, hey, why where's the gauze? Maybe the surgeon put gauze on the upper abdomen. When the another surgeon do the different thing, he move around and pack another gauze. So actually in the end, the gauze can be missing because the position. Careful bowel can move. Even you retract for a while, where's the gauze? The gauze go on top. So careful in abdomen. And then obese patient. If you assisting surgeon with obese patient, imagine the thick wall and then the cavity. Sometimes surgeon you have to use the big retractor to retract, and you pack the gauze. Sometimes we can't. I mean, you have to find it's not easy. So it's more risky when patient with obese. And same thing like I said, 2 times more when there's more than 1 team. For example, like gynae operation for ovarian tumor. Sometimes they call surgical for surgeon for standby. Kan sometimes the bowel injury, whatever complication. So this time you must be careful the nurses in OT. When there is 2 team operating, be careful when you count the swab. Or if the surgeon want to take over, please check your swab is it correct or not, because the ONG will not remember what surgeon put inside the patient bed, abdomen. So you must remember that. Blood loss. Sure, like in intra-ab, with the liver injury, spleen injury, bleeding everywhere. Sometimes this can happen because people concentrating more to maintain BP. Kan patient bleeding a lot, you think more to packing, then you don't realize how many pack inside. Thing can happen, human error lah. Your intention good to help the surgeon, but sometimes even how urgent is this, please remember, do something to remember how many gauze. Most of the incident happen when there is too many things, trauma, especially if thorax, abdomen and limbs. Imagine, normally we do 1 team by one after another. Sometimes they simultaneously. For example, the surgeon open the abdomen, the orthopedic do the leg part, you must have 2 separate teams. If not, you miss the count. And one more thing, if you remember like colorectal surgery, the abdomen clean, right? When they do the bottom part, perineum part dirty, so the set must be totally separate. Or sometimes in difficult situation, the surgeon request so many instruments. They want this retractor, they want that retractor, end up so many retractor. And then sometimes this can happen. So be careful when this thing happen, you must take extra precaution. Okay, what procedure associated with increased incidence of retained surgical foreign body? The top on the list is abdomen. Common abdomen. Because abdomen, lot of compartment. You imagine lah, below the liver, then small bowel. Remember small bowel can move Some more when you retract, you pack, you retract, you put the bowel, bowel can move. I think routinely the surgeon will do insert the pack. Minimum two pack. Or they put another pack cover protect the wound. Invariably sure there is pack in the abdomen. So you must make sure the nurses assisting, whoever to must remember how many pack. Okay. Second one is gynae procedure. Gynae procedure normally they related to like seizure with bleeding, complication they start packing. And then few common incident patients who in the hospital when they found pack gauze at the episiotomy wound. Seizure kan nothing, so many seizure, delivery per day, and then sometimes people rushing, closing, they forgot. They pack gauze in the vagina lah, this thing happen. Orthopedics, spinal, more to the instrument. Kan orthopedic they look a lot of screw, so many screw. So please remember, sometimes the screw, they need 2 screw or maybe 3 screw. So they put 4 screw or less than that. Sometimes you may see, they make sure that the screw is count properly. If the surgeon use 2 screws, suddenly got 3 there, problem. But one loose screw loose. But screw I think no problem lah, because it's the metal, platinum, so it's not cause reaction, but gauze cannot. But one thing, if they travelling, MRI difficult lah with the foreign body. In metal, sometimes it's ungood for patient because of the MRI. MRI sometimes you can affect the steel. Okay, it can happen when there is a complex, I think you all know lah, complex surgical procedure. I think once a while, we surgical, normally they do the damage control surgery. If you know what is damage control surgery, normally like liver injury, liver laceration, you can't repair the liver. Because most of the hospital kan, like small hospital, they cannot refer to hepatobiliary. Patient dying, patient collapsing, you cannot refer. So the surgeon have to do damage control surgery. Maksudnya, they open the abdomen and pack. This pack mean to live inside too. Memang kita simpan. So what we do, we pack and then we plan to re-operation again in another 24 to 48 hours. So please remember, please write the count correct. For example, 4 abdominal pack, 3 roller gauze. Mention post-operative note, your nursing side, 4 gauze in the 4 pack in the abdomen, 3 roller gauze. Because when the next team operating again, they need to find out that 7 whatever number that you recorded. Suddenly ada recorded, so the next operation surgeon put, okay, 6 cukup. Actually got 1 more left inside there. So careful, make sure document properly. How many? This one intentionally memang we insert the gauze or whatever, but we going to remove the subsequent operation. Another thing for the surgical procedure, commonly they put pack for surgical procedure. For example, hemorrhoid operation. Last time, the surgeon normally put the gauze because after hemorrhoid operation, they were bleeding. So they put pack into the rectum. The next day, normally we should remove, or patient normally defecate, they withdraw. But you must record, this is surgeon part lah. Or maybe your side was must report that there is pack in the rectum. Bukan unintentional, intentional. So please don't forget to remove for nurses in the ward. Because few patients, the nurses don't know, then the houseman also some more blank, and then patient went back. Sometimes 2 weeks later, they went to private hospital. Private hospital said, how come? Got gauze? And then patient come. Oh, doctor forget to remove my, they become medical legal issue. Actually unnecessary. And one more thing, when you assist surgeon, sometimes they do perineal procedure, the feces coming out, keep coming out. Sometimes they put gauze. 1 gauze to prevent feces from coming down. So at the end of the operation, please remind surgeon, boss, ada benda dalam rectum, please remove. Sometimes you all won't ignore because it's in dirty place. Abdomen, sometimes you all eager to know, abdomen kan kena count. But sometimes you forgot the one packing. So must remind the surgeon. Boss want more ghost. For us, normally we trust you all. If you said something missing, we look for it. And make sure your surgeons follow you all. Sometimes say, no, I don't think no. No, boss must something there. So you must set for your surgeon to find it. By group lah. So far, nobody died because of this lah. Luckily. But I think at the end of the presentation, we show case where patient die. It happened in Malaysia. Okay. More common, patient readmit again lah. Normally for gauze, simple gauze, for example, the gynae procedure, or they come back few weeks later, because the gauze cannot stand longer in the body. They cause infection. Kalau macam episiotomy wound, patient will present with perineal pain, discharge, so they will go to GP, whatever lah. End up, they found something. Or another thing, when you detect it, you have to explore again. Few patient yang surgeon detect there is something missing, sometimes it's lucky lah if you remove immediately intra-op. Sometimes patient already extubate, dah pergi recovery dah. Kau tak cukup. Patient dah recovery, dah extubate. Got one incident, patient already extubate, and then he's going to send to the ward. Luckily, they said him, Doctor, I think count is incorrect. Luckily, we can push back patient to OT. But unfortunately, the patient have to second GA. But what happened if patient already in the ward? Sure, got medical legal issue. Sometimes we say, baca. Because sometimes when in the ward, when you order X-ray, Doctor nak X-ray apa? Saya dah operation dah. Then they query, sure ada mulut, bawa PPK kata apa? Doktor buat tu sebab ada benda tinggal. Sometimes kepoci banyak tau. You careful lah, you dengan medical legal ni kan, people like to make a rumor bigger. So careful, let's try to avoid it. So thing can happen Okay, so this one unnecessary longer stay in hospital, and then you need to operate patient again. I think one incident in Seremban, quite long time ago, patient underwent open cholecystectomy. Dia put drain. Normally kan you use protect drain, right? Protect drain. I think when the student remove, actually this one nobody realized. After 3 years later, she presented with pain. They diagnosed with pre-colic lah, upper scope, lower scope, everything done. The funny thing, people miss when there is plain X-ray. Once plain X-ray done, actually there is retained drain, but nobody realize. People concentrate dengan gallbladder. After that, they work out for utriculic. Unfortunately, patient got utriculic lah. With my uterine stone, got gastritis. Then once they said, well, we need to the IVU. Okay, this very good, very expert radiologist. He's very sensitive at prelim. Oh my God, I think I saw foreign body. Imagine so many surgeon or MO review the plain X-ray before, nobody realize. Even that pun people miss it. Because people don't think of written bone. They think of gallbladder stone, they think of uterine stone, why looking for something else. So this reporting radiology comment, then call surgeon, I think we got problem. I think there is written drain. So we try to track back, it's not easy because 3 years later, documentation, we managed to get the case note, but documentation is, we don't know, mungkin the student nurse remove the drain or the doctor no documentation. That's why we decide after that incident, we don't use any more protect drain. Protect drain, tata you all have to make the whole hole kan? If you make the hole more than 50%, they can break. Normally in OT we divide, I think last time they decide for protect drain must have 3 holes. So if no 3 hole means something missing. So it's standard 3 hole. All protect drain 3 hole. Up to your hospital lah, mean you must make standard. So when they put the drain, they must make sure drain come out with 3 hole. If turn out to be 1 hole, sure some. Because protect sometimes not really clear. Because protect tak ada radioactive material. I think all protect is plastic. Why? Because the thumb ONG also never use radioactive. I think thumb ONG here, right? If protect, if really necessary, we must make sure the hole not more than 50%. I think main plastic material lah, you make 50%, kalau logic memang you can break. Sama dia ada teknik kan, ada modul yang rotate, salah sudah dia pump kan tu. Resistance je tadi tu, okay lah enough. careful must rotate, there's technique lah. Sometimes we left to junior, kadang-kadang last time some student nak remove the drain. Now it's because of the medical error or sometimes more to annually sampai houseman now kena buat drain, sometimes nurses no more remove drain anymore. Now done by doctors, right? Because things change lah, but last time I think nurses no harm doing it because the important thing you know what you need to do, but now I think because of people scared, thing happen, let doctor do lah. Doktor pun houseman same thing. Nanti ke surgeon pula kena remove drain. Think now is that whatever happening is now is like that. Become more senior people have to do the thing can be done by junior people long time ago. It's different. The scenario different. Okay. Fistula. One story in not here. The gauze, he wrote the sigmoid and then come out in the NS. He wrote because the situation, he wrote the bowel and then come out in the NS. Itu laki lah. One patient, the gauze, he wrote the duodenum, he wrote the sigmoid, form the big cavity, and there is bile there. Actually, when the surgeon open up, it's terrible because when we don't remove that thing, okay. When you remove, imagine the hole in the duodenum, the hole in sigmoid, the hole in CBD. How to repair? It's always scary. It's disaster. And then end up we have to pay for patient lah. Legal suit. Okay, this photo is the tumor. If you see this, it's tumor. When open up, you see the gauze nicely inside the tumor. Gauze still intact. This one how many 20-30 years later. So the surgeon operate tak tumor lah. When they open up, it's a gauze. But this patient survive lah. Okay, how to prevent it? For you all, please remember communication. I think now safe surgery, safe life did help us a lot. I think safe because for your information, safe surgery, safe life cover everything. The count, everything cover in OT. Kan? OT safety, okay. Count is the only way we can do lah. We don't have special gadget lah to count the gauze, but we have to manually count lah. Okay. How to count? I think if certain people they say 3 minimum, right? If certain advice 4 count. First count is when instrument or sponge are first unpacked when you open up. Second count before you start, surgeon start the procedure. And then third, bila surgeon said, I'm closing. Sometimes you all quiet kan? I'm closing. Okay, surgeon also sometimes shout down there kan? Because safe surgery now you shout. You closing now. Okay, and then when before the skin closure. I'm closing now tu maksudnya they going to closing the abdomen. Before surgeon start closing the skin, you must make sure the final count. And then please inform the surgeon because nanti dah skin closure ada BC, ada rasa gauze tak cukup lah. Then you are trouble. Takkan you nak undo this, you have to like undo the laparotomy and laparotomy closure, so better make sure you count fast. When the surgeon start closing the abdomen, count. Because if it's not correct, you still got time, the surgeon will stop closing, search for it and then continue the work. Small size sponge or gauze. Normally kan kalau surgeon once they open, when they do skin incision, they use gauze. Once they open the abdomen, please don't use for your surgeon lah, kata doktor, jangan pakai gauze, boleh pakai gauze. Abdomen pack lah. Sometimes you kena advise juga surgeon dia adik-adik junior surgeon, sometimes they don't realize they use gauze, so many gauze. Doktor guna pack lah. So actually normally we advise my junior if enter abdomen, no more gauze. Pack big and then got string kan. But now new era of laparoscopy, we go back to the small gauze. But then another thing, important thing about this one lah. Sorry. Even use small, avoid use of sponge or towel without radiopaque. Remember the green anesthetic punya gauze mana ada radiopaque material, right? So the green gauze never go to the abdomen. Or they should not be in the surgical field. So kalau GE buat procedure, make sure they clear up no more once we start operation should be clear up. And white gauze normally they use when they insert CBD, right? I don't know if in your hospital you use the radio opaque material gauze or plain gauze. I think most of us use plain gauze for CBD insertion. I mean because that's why when you use plain gauze, make sure you discarded gauze before you start unpacking the radio opaque. Because incident in Seremban last time, because they kan kau cukup lah, but they included the gauze yang used for CBD, then it's missing lah. So careful Or one thing bad habit of the surgeon, when they change glove, sometimes the gauze tu dia masuk dalam glove. So if you cannot find the gauze, find the glove. Count the glove yang surgeon. That's why glove pun jangan throw into the different, maybe still throw on around the floor of when you count the gauze, easy for you to counter check. Sometimes they throw in the yellow bag, like anesthetic. Anesthetic difficult. Use less number of sponge, and then for surgeon and nurses must do thorough count exploration before you close. And one more thing for major surgery like damage control is sometimes advisable for you to X-ray for post-op, just in case, because sometimes multiple operation, sometimes you're not sure, you count them first count, second group, especially yang shift morning go back, the shift afternoon shift, you must recount. If not sure, please do the X-ray. Okay, in overseas they got specialized electrode system, radio frequency identification. This one they can tag the gauze and they can count, but we don't have this. It's accurate. They can do within 3 seconds and 100% accuracy. But for us, I think we still use manual. So please use the gauze whatever with the with radio marker. This one can detect by X-ray. So the blue thing is detected by this one. So use only radio opaque gauze in the OT. Scalpel I think no problem lah, sure can be detected by X-ray the gauze. Okay, we don't want this lah. This is Malaysia case Okay. There's not inside the operative procedure of spine surgery done in private. So one of the nut is left inside two. The nut, this one I think should be no issue because if no dangerous organ close to it should be no problem. Unfortunately, this one close to the big vessel and nerve. So no issue to remove, not to remove. If remove can be danger patient life. Not to remove also, if later migraine can cause problem. Now become dilemma, so nobody dare to operate. But luckily she's doing well, except this progressive thing later she may have problem because the foreign body very close to the nerve. Next one I think come out in papers. I don't know whether we can pay 8 million or not. This patient passed away. I think more related to gynae operation, they leave the PAC or gauze. So patient come back with septicemia. I think not just because of that, so a lot of things septicemia. Sometimes when patient leave with septicemia, sometimes when you remove gauze, patient still succumb to it because too late. I think this one sometimes people miss. They don't think. No lah, I don't think gauze. Normally the ego of the surgeon sometimes be problem. So they say I don't think. No, sometimes it's that. This patient passed away because of the septicemia. Okay, important thing, this year alone, actually the ministry pay $500,000. This year, from January to June this year, MOH, Ministry of Health, have to pay 500,000 for case like this. So actually, most of the cases is a lot of emergency gynae, surgical and the orthopedic. So sometimes if become noted negligent, sometimes you have to pay because ministry memang pay for it. But the doctor, whoever involved, sometimes you need to pay the what we call, sometimes they send depend whether they will be medical legal medical inquiry lah, this one and not ending. Sometimes be months, years to settle this case. So you have to attend the court lah, medical inquiry, make pengarah lah, and then so many things. End up, ministry have to pay. If negligent, foreign body ni difficult lah, normally dia kata neglected. If you already count properly, then may be different, but majority sure there is some mistake there. Kalau scalpel blade inside dia, tak logik kan? Scissor, don't be surprised scissor ni lamina abdomen, should be not, kan you count scissor right? That's why should negligent lah. So be careful I got one story that one MBA, I think, not MBA lah, I think not sure. The count not correct, you take another gauze, he put them. Count correct. Now they very intelligent lah, they dangerous. The count not correct, they say, how come I try? He's scared, the surgeon will scold him or what? He pull another one and put added. So now crack lah. So careful, don't do that bad attitude. And one bad thing happen, that bad attitude. Okay. I think for take home message, this if it happen, is serious problem. But sometimes we cannot completely prevent. The human error you can't completely prevent. So hopefully you all, for after this, be careful in OT. To make sure count, do your job je. Make sure count correct. If you think you need to inform the surgeon, please inform. Don't be scared. Let him scold you lah. Rather you been suing mahkamah. I worried that my surgeon angry with me, so I didn't count properly. Cannot. You cannot answer that in court. Surgeon normally they oblige. For me, normally I trust. If nurse say no enough, not count not correct, I will search for it lah. But careful because I got experience laparoscopic surgery. Laparoscopic surgery we use small gauze. So we put this gauze, and then after that we convert to open for a while lah. And then we go in for laparoscopy. And then we say, where's the gauze? Small gauze. We search, we retract the bowel, everything, we cannot find the gauze. End up, I actually wear the gauze, small gauze in the stomach. So that's why from that experience, we said, no, when you put the gauze laparoscopy, you put and remove. No more like put the gauze and then until I continue with the other part. So put gauze and then take out. So you must remind surgeon, Doktor, gauze tu tak keluar lagi before they convert to open. Sometimes for you all, now new laparoscopic protein, we must be, maybe it was new for you. Please remind surgeon, when they convert to open, please remind, gauze belum keluar, laparoscopic gauze still inside. Please remove before you convert to open. I think one more, I think I want to show the photo is not, I forgot to. Okay, you know what the top is? Tampon, right? Tampon. This one is not because of surgery. The tampon was left inside for CT scan procedure for gynae. People don't realize it was stuck there for patient was in HDW and then the nurse said, macam siapa? Surgeon ada buku apa-apa kat perineum, vagina. Because they were not related to surgical buka-buka vagina. So end up, we find out is tampon. Actually related to CT scan procedure. So even this one can cause problem because there's many discharge. People don't realize, but luckily the string is outside. The string is around the vagina. The nurses cleaning, how come got post-laparotomy